Well, thank you everybody for joining us this afternoon, both here on Zoom and also live on Facebook, to discuss the challenges of living on watch and wait and understanding better how to cope and manage watch and wait, and also to tackle some of the challenges that day-to-day challenges patients experience with the support of our healthcare team and our terrific panel from the universities, hospitals of Wales and Southampton, and our terrific patient panelists. Just as a note to confirm to everybody, we're not accepting today spoken questions. We tried this in past events, but I think from the numbers and the number of questions we have, please, if you have any questions, drop them into chat if you're on Zoom at any stage. If something piques your interest or if you've got something you want to say, these will be collected and put on a document that I'm going to keep tabs on as I help to field the questions after the talks to the Q&A, to the panelists in the Q&A session. If you're on Facebook, please also, under comments below, please also drop any questions in there. We have a colleague monitoring Facebook who will also forward your questions. So hopefully we'll have a really good discussion to discuss how to live on active monitoring, watch and wait. I apologise, I didn't realise my video wasn't on. There's a technical hitch. Thanks for the reminder from my colleagues. I can't believe it after 2 years of doing this, and you know, with COVID and with people being a little bit more isolated than prior, it's an important webinar today. So please, you know, use your voice and drop your questions in. Can I take this opportunity then to introduce our panelists? If the panelists could introduce yourselves one by one, who you are, your roles, responsibilities, your connection to CLL and connection to watch and wait. Why don't we start first with yourself, Chris?
I'm Chris Fagan. I'm Emeritus Professor at Cardiff University. Formerly had many years working in the CLL field from the days when our only therapy was chlorambucil to where we are today.
Thank you, Chris. Maybe Charlotte.
So I'm Charlotte Bloodworth. I'm advanced nurse practitioner in Cardiff. Used to work with Prof Fagan. So I've worked in haematology for about 19 years, and I've been in my current role probably for the last 5, just over. And part of that involves consulting on the sort of CLL clinics.
Thank you, Charlotte. Bryony.
Hello, good afternoon, everyone. My name is Bryony Tyrrell. I work at the University of Southampton General Hospital with Prof Facconi. I've worked in haematology for about 4 years now. Started in research trials, and I've recently moved to the lymphoid clinical nurse specialist role.
Thanks for joining us, Bryony. Maybe Liz. Liz, I think you're muted at the moment. You might just need to unmute yourself.
There we go. Is that? Yeah.
That's it. We can hear you now.
My name's Liz Miles. I'm a CLL patient. I've had it for 3 years, approximately. Yes.
And you're living on watch and wait for those last 3 years.
I am on watch and wait, definitely. Yeah. Yes.
And thank you for joining us. I'm glad we got you on board, and we got through some of the technical glitches that we've had this morning, and some of those my own. So thanks for your patience. And John, last but not least.
Hello, my name's John Price. I've had leukemia for 20 years. I've been watching and waiting, and nothing has happened for 20 years. I've been involved with helping leukemia care, and really respect everything they do. So I'm always happy to help.
Well, John, thanks for supporting us again today, and let's hope you have another 20 years watching and waiting and nothing happening. From a process point of view, just to let everybody know how this session is going to run, The Prof is going to give an overview talk in a moment to explain the clinical aspects of why watch and wait and why the decision's been arrived at and potential challenges of watch and wait and the process. And then that will be followed shortly after with a talk by Charlotte, who will provide a talk from a supportive care overview and perspectives of the clinical nurse specialists in supporting patients, how patients should be supported, how they can be supported, how you can connect, and also aspects that can be shared there on how you can cope and live as well as you can whilst on watch and wait. And then we're going to follow that with a really inclusive talk where we've collected quite a few questions from patients already. And this is when you in the audience can also drop your questions. And if you're struggling with issues, if you've got questions you always wanted to ask, please do drop them in chat, or if you're on Facebook, drop them in the comments and they'll be forwarded through. So from that point of view, then at the end, I'll run through a few slides just to share with you some information that's available. And I think Charlotte's got a considerable amount of information also to share with you. So hopefully this will be an informative webinar. And just to let you know, this is a recorded session. The recorded will be made available to you afterwards. And any information that you need from slides or anything like this will be provided in the follow-ups. So without further ado, Chris, can we give the floor to you?
Thank you, Nick. Good afternoon, everybody. Watch and wait in CLL has been around ever since the disease was first really recognised in the early 1970s. We actually know 200 years ago, patients had CLL from historical records, although at the time they didn't know what it was. In the early 70s, Binet and Rye devised a staging system which we still use today. Our only effective treatment back then and really into the 90s was a drug called chlorambucil, which was an oral mild chemotherapy agent, and was shown in those patients who are unwell with CLL to relieve symptoms and treat the disease. Eventually the disease broke through, chlorambucil was no longer effective, and at the time there was nothing else to give. However, having found that chlorambucil was effective, people then started to look at what about using it in those patients who don't have any symptoms for CLL. CLL is probably unique. Anywhere else, you would think the earlier you diagnose a leukemia or a cancer, the better you do. The whole point of people examining breasts or reacting if they're losing weight, blood in the stool, blood in the urine, to try and diagnose cancers earlier. But in CLL, to date, it really hasn't made much difference. We know that 70% of patients are found by chance on a routine blood test. Unfortunately, CLL is a disease of the more mature in the world, and unfortunately comes maturity, comes failure of other things, the prostate, the gallbladder, the hips, the knees, etc. So they have a blood test done, and lo and behold, there's a high lymphocyte count, of which 90% will actually turn out to be CLL in adults. So in 1998, Daguerre reported the 2 French studies looking at giving chlorambucil therapy to patients who are asymptomatic with early stage CLL. And in fact, it made no difference to outcome. If anything, you were more likely to die earlier with the chlorambucil than with the watch and wait approach. To show that anything the French can do, we can do in Britain, Professor Kotowski at the Marsden reported the British data a couple of years later, showing exactly the same results. Chlorambucil gave no benefit, and if anything, was potentially harmful. What you'd want in a therapy is something that works really effectively, and chlorambucil didn't do that, but wasn't particularly toxic, and chlorambucil wasn't toxic. But if we got new agents, fludarabine alone, fludarabine, cyclophosphamide, rituximab, bendamustine, rituximab, these early studies were repeated with watch and wait versus chemoimmunotherapy, but none of them showed an overall survival advantage, and those particular agents were more toxic than chlorambucil and came with their own problems. So the dogma was still, it's watch and wait for early stage asymptomatic patients. In the early 2000s, criteria were put together who should be treated with CLL from the watch and wait. If you're not going to treat immediately, what are the trigger points at which you should treat? And those involve B symptoms, weight loss, fatigue, fever, night sweats, growing lymph nodes, growing spleen, growing liver, hemoglobin falling, platelet falling. It doesn't really involve the white count much, although a 50% increase in lymphocyte count at 6 months for some is a trigger to start treatment. But mostly we do it on symptomatic or obviously clinically progressive disease. And those were modified again in 2008. The most recent study reporting watch and wait is the German CLL 12 study, which was reported this January, comparing ibrutinib with watch and wait. Ibrutinib is a very, very effective single agent in CLL, and we know that from studies in people who've required treatment. And it was deemed to be fairly non-toxic, certainly compared to fludarabine, cyclophosphamide, or bendamustine rituximab. So we thought this study was well worth doing. What it showed, it's reported in January of this year, is it did reduce what was called event-free survival. What the hell does that mean, I hear you say? Well, you can define it how you want, and they defined it as not needing another CLL therapy because your disease hasn't progressed. Well, that was unlikely to be the case because ibrutinib is an effective treatment, and you didn't die of your CLL. Well, that was unlikely to be the case because you're on ibrutinib. What it suggested is the side effect profile wasn't significantly worse in the ibrutinib arm, but in fact, they've had a lot of criticism of that study subsequently because you were 10 times more likely to develop atrial fibrillation, which is a well-known toxicity of ibrutinib. You're more likely to have ventricular arrhythmias, which are the cardiac arrhythmias which are life-threatening. 40% of people developed hypertension on ibrutinib. So having told everyone it was significantly better for event-free survival and it was not more toxic, the actual conclusion was you should still watch and wait because the benefits weren't worth the risks. So even with ibrutinib monotherapy reported in 2022, 24 years after the original DAGIRO, we're still no further forward with this situation of if you're well, if you're asymptomatic, and your disease isn't obviously progressing, watch and wait is the standard of care. I think one of the problems historically is care is meant administering therapeutic agents. And I think there's been an awful lot of work done by the likes of Leukemia Care and other charities that actually living well with CLL, whether you're on treatment or off treatment, is really what the goal should be. The goal shouldn't be just handing out therapies. It's keeping people well mentally and physically for this disease, which John has emphasised, you can have for over 20 years. The longest patient I had was diagnosed in 1979. Unfortunately, died in 2013. Never had treatment for their CLL. They died age 93, not of CLL. So that person had done over 40 years with CLL. So CLL, the battle for CLL, certainly early days, is coming to terms with it. What does it mean for you and what your coping strategies are for it? Thank you.
Thank you, Chris. That's a really helpful way to set the scene of why watch and wait. And I'm sure we'll have plenty of questions for you during the discussion. Charlotte, I think it's really great to have you and Bryony with us today. So your talk is really important because I think when push comes to the shove, the majority contact is and support comes from clinical nurse specialists and the nurse teams, or it should. So we're really looking forward to your talk and what you can share. And we noticed you've been doing quite a lot of work in Wales recently, highlighting these issues and how clinical nurse specialists can support patients. So yeah, please. I believe you've got slides to share. If you could share the slides.
Yeah. Thank you. I'll just try and share my slides now. Let me just get this up.
Yep, we can see your slides.
Lovely, brilliant. So I just want to start with a little caveat to say that I'm not an expert in all things support, but I do have a wealth of experience. And I have just recently finished a sort of all Wales project that we did to sort of highlight what support is available. So I have put a few slides together initially really just to make sure that everybody knows that there is a lot of support services out there. So I've just sort of done it to show you that there's a big support network out there for you. Then you have some services that are specific to cancer. Then you've got the services specific to hematology. And then you've got your sort of local hospital-based services. And it does sort of move in that sort of pyramid shape, you know, because your local hospital only has limited resources, which is why you need all these different layers of services available. So just going through each bit of the pyramid. So the local and hospital-based support services, you've of course got your hematology team. So you'll have your consultant-led teams. They'll be the ones that give the diagnosis. They'll be the ones that take all of your details and go and discuss whether you need treatment, whether you don't need treatment. And then part of that team, of course, is the clinical nurse specialists. So our role as clinical nurse specialists are people with a lot of knowledge and experience about leukemia, about all the treatments. And we're there really to be a point of contact, to be able to discuss things through with you, and also advise the sort of team, the wider team. We're sort of that link between you and the hospital team. That's how I see it. It's a massive role, and there are lots of things that go with it. I've just done a sort of put up a little graph here of all the things that are involved with being a clinical nurse specialist. But really for you, you've just got to know that they're your point of contact. And I would say they're the most important person of the team for you to get to know. You know, even if you never see them, if you just go for one appointment a year, they're your contact. So definitely get the details. I'd say each hospital or health board has cancer services. So Macmillan in Wales are the ones that sort of run our cancer services. They have information points in all hospitals, and they have some support workers as well. So different hospitals will use their sort of cancer support workers in different ways. So again, find out what's local to you. Also linked to this are the psychology services. So I'd say everywhere will have a cancer psychologist service, and they're sort of professionals that can help teach you techniques to cope psychologically. So moving on to the next layer, the specific hematology support services. So I've put really the four main ones here. I'm going to just flick through them. But really, I would say each of them have their own selling points. All of them offer a massive support. So, of course, leukemia care, webinars, support groups, a forum, you know, there's a massive things on there. So if you haven't had a look at the website or had any contact with the charity, I would definitely recommend it. And of course, the CLL support group, again, you know, run by people that have CLL, have a lot of understanding, know what it's like to have that lived experience. Lymphoma Action. So even though CLL is a leukemia, it is actually a lymphoma. So I won't go into the details, but Lymphoma Action do incorporate CLL as part of their support. And again, they've got a wealth of services, a wealth of courses that they run, self-management buddy services, and a lot of information on there about COVID and how to protect yourself and things like that. And Blood Cancer UK, again, another fantastic charity that have a lot of services out there. So I would say definitely have a look at all of those. And then, of course, you've got the national cancer charities. So these aren't hematology specific, they're not leukemia specific, but really they do offer you as a leukemia patient a lot of support. So I've picked two again. So particularly Macmillan. So Macmillan do so many things for cancer services, but they also do a lot of things for individuals with cancer. They have a lot of information, a lot of courses that they run. A lot of experts are involved with Macmillan, do a lot of projects. Again, really interesting to have a look on their website to see if there's anything on there that would be good for you. And the other thing are Maggie Centers. I love our Maggie Centers. I recommend all patients go and check out the Maggie Center. The only thing about Maggie's is they are only in specific places, usually large cities. But if you can go to a centre, they're absolutely beautiful. They always link up with an architect, and their buildings are amazing. And they're supposed to be an area where you can just drop in, have a coffee, have a chat to the people that are there. They run lots of courses, fatigue management, lots of things. So that they're worth looking at. They also do have an internet version of support, again, which is really good. But the centres are especially good because you can see psychologists face-to-face, counsellors, things like that. So if you haven't heard of them, definitely check them out. And then there are the non-cancer services available. So, you know, if you really are having problems with anxiety, with worry, there is a lot out there that isn't cancer related. In Wales, they do have like an active monitoring course for 6 weeks where you can get help with anxiety, depression, things like that. So a little bit off ball really, but still really helpful. And I think really it's about having a mix of things available to suit everybody. And I would say really the biggest support are your friends and family around you. So really you want to accept help off your friends and family. A lot of people are very independent, but I always say think of it from their point of view. They really want to help, you know, they feel helpless, out of control. So, you know, let them in, let them support you. So the trouble is there is a lot there. I think there's a lot there, but really it's about how do you use what's there? You know, does it fill your need really? And that actually takes a lot of hard work on your point, on yourself really, to find out, you know, what are your triggers for your worry and anxiety? You know, is it sort of physical things that, you know, you can work on, or is it a lack of information? You know, everybody, I would say, has different issues, different worries and different needs really. So you need to take the time to focus on yourself. You need to find out, you know, what are your particular triggers? And I would say, you know, if you have been put on this sort of surveillance or watch and wait, you should really think of it very positively. And this is your time to strengthen yourself, to change your lifestyle. And really, you know, you may not ever need treatment, but in theory, you can, you know, get yourself ready for treatment. You can improve your physical health, become more active, get better sleep, you know, cut down on the alcohol, the caffeine, look after your mental health and try and find that sort of resilience and that sort of head space for yourself. And then also get the people around you really, find out who supports you the most and keep them close. And again, everybody is individual. And I think once you can get to the core of your needs and what you can do, then you can use those services that are available to your advantage. So I would say it's really hard work to do that, because you need a certain amount of worry really to remain vigilant, to know when your problems are going to be there or what to look out for. But you also don't need so much worry that really it becomes overwhelming and you know, you can't cope with things. And that's a really hard sort of tightrope to walk. And it does take, I think, time. It's in a way, it's a bit of a process. You have to go through a number of things until you find that sort of restful area where you're on that sort of tightrope of where you want to be. And just to shout out to all the people living in Wales, we have all the hospitals in Wales, every single one of us have got together and done an information video that's available on YouTube about what support is available for people. And I would say, you know, there is a lot out there. You just need to know, really go and find it, and then find which bits you want to use.
Thank you, Charlotte. These are really important information, and I think we'll make sure we share the slides with everybody afterwards. Well, already we've got lots of questions in, and I think one of the hardest things of living with watch and wait is obviously its counterintuitive nature. You've been diagnosed with cancer and then the feeling of being cut adrift, and how do you maintain contact with the information you need and your care team to help you through these phases? So one of the first questions is, you know, what is active monitoring? What is active surveillance? Is there a flaw in the words? Is it watch and wait? I'd like to actually ask people, should they watch and wait? Because I think that's a fundamental part of the problem that many people have identified. And I just wondered if people could kind of share their perspectives of what they either advise or what they've learned through the years or as patients. So have you got anything you'd like to say on this, Chris?
The only thing I would say, Nick, is the CLL patients are like the rest of society. They're no different. Before they had CLL, they were just like everybody else. Some will worry more than others. Some are more robust. Some would like to try and forget about the disease. Some people want to know everything about the disease, what's going on, all the new developments. And I think it's important, is Charlotte emphasises, what do you want? What's your best method for actually managing this? Do you want to know everything? You're that sort of person. If you think you're out the loop, you're going to worry about the fact you're out the loop. Or are you someone who actually, well, I feel fine, I'll worry about it when I start feeling ill, and almost can compartmentalize it and seal it off in your head? Every patient is different. And I think one of the things, it's about that relationship between the patient and their healthcare provider, that they have complete trust in their healthcare providers, that should something happen, should they think they need help, that there is help readily available for them. And the analogy I use is, some people, we're talking about a safety net here, the hospital or the supporting services providing a safety net. How can we make the mesh on that net as narrow as possible, that people don't think they're going to fall through it? The worry is people think the mesh is so wide, they're going to fall through it. And therefore it is about trying to find what is the right way for you. And that's an individual thing. And the really good healthcare professionals, and I can say this because I'm no longer looking after patients, understand that every patient is different with different needs. We're not treating CLL, we're treating individuals.
Thank you, Chris. Insightful, and obviously it's all good if you can connect with your care team, and I think we'll come on to that from the point of view of questions. We've got quite a few questions about how frequently you should expect to be have your monitoring consultants, relationships between GP and secondary care. People don't seem to fit. But Charlotte, somebody raised earlier that not everybody worries. So I guess what we're really emphasising here is the wait aspect of watch and wait. Have you any thoughts?
So I would absolutely agree with that. I think there are lots of people that don't worry at all, that are really happy with the explanation that was given, and adapt to that watch and wait time, and others don't. So I would say there's just an absolute continuum out there, from worrying too much to not worrying at all, and everybody is different. And that's really the one thing that I've learned over the years. You definitely can't have a one approach to everybody, because everybody wants different things, and it's finding out what people want, how much support they want, where they want it from. It's really sort of, I would second what Prof said, getting to know each other, your healthcare team, the patient, and the longer you know each other, the more you sort of can understand what people want from you and what they need to be signposted to.
Thank you, Charlotte. Maybe we can use this session to actually help people to connect so that they can develop these relationships and people can manage to get the information they need in a timely manner. I think that's part of the problem of a lot of people living with active monitoring, active surveillance, watch and wait, watch and worry. Bryony, you've been very quiet, and it's about time we actually asked some of your experts' advice and how you find things in Southampton with your patients. Any insights?
Yes, I think obviously the last 2 years have, with the COVID pandemic, have emphasised the sort of those people that do worry really have worried, a lot. So it's been a very anxious time for a lot of people. So I think, as Prof and Charlotte have said, if you've got that connection and those contacts, you can get reassurance and advice. We are starting to see people in the hospital more again now, so hopefully people aren't feeling so isolated as they were. I feel like things are improving, but the last 2 years have been very challenging, I think for patients, and I hope it's getting a bit better now.
I think, and many people are commenting that COVID has been a big game changer in all of this as well, that's added to the lack of connection and the worries. I guess I'm going to come to you, John. 20 years on Watch and Wait. How do you feel now when it comes to waiting and watching? And was there a point in your journey when things changed for you? Or have they changed? I shouldn't be assumptive. Have they changed? Do you still watch and wait and worry?
Yeah, they've changed considerably, because 20 years ago, when you first told, your life just changes overnight and your stomach drops and you come to terms with it, with all the fear, and then you think, right, okay, let's get on with it. And I'd liken it to, do you remember the old adage, a watched kettle never boils? Well, if you think about watch and wait, I kind of sat round waiting for something to happen. And then I realized I was feeling a bit moribund, a bit inactive. And I had a wonderful, more senior consultant at the time, 20 years ago. And I said to him, I'm being really precious and I'm waiting. What's going to happen? And he said, nothing, just get on with it. But remember, I've never dealt with anybody, he said, that's died from being knackered. And he said, get out there, get on with it. Don't watch the kettle boil. Go and get on with your life. And it was a tremendous piece of advice. And I've spent the last 17 years following his fantastic advice. The thing that's cocked it up is COVID, because we've had to, people keep telling us we're extremely vulnerable, so you've got to keep your head down. And so the exercise, the getting out, the traveling has all gone to pot. And so everybody's right in saying that COVID it is a game changer, because we've not been able to let the beggars grind us down, or opposite. So yeah, I think if you can, don't sit there waiting for something to happen. Get your finger out, get on with something else.
Thanks, John. And I think COVID has almost made us all have to wait, whether we're watch and wait pre-treatment or post-treatment. And and this has been mirrored by comments, people saying that they were okay with active monitoring for 9 years and now COVID's blown it out of the water. And I think there's one thing, as I haven't alluded with everybody, but those that know me know I'm also a CLL patient. And I can't imagine the emotional and psychological challenge of being diagnosed during COVID, and somebody's just shared there. How can you actually come to terms with balancing that? And maybe that's something we can discuss. Liz, I'd like to come to yourself. You've got experience in the background in healthcare, and obviously now yourself a patient, and you've been on active monitoring for 2 to 3 years now. Where do you see yourself at the moment in your journey, and how are you coping? And are there barriers that you're needing to overcome that maybe we can also discuss as well?
I don't think I've actually found my safe place at the moment. And I don't feel I've been offered that sort of care. It's only hit me recently. You know, when you're first diagnosed, you're quite glad that you haven't got to worry about being treated and side effects and all the rubbish that goes with it. Now, after 3 years, I find that suddenly it's all become a big worry. I don't feel I've got the support from the hospital. My only real route of support at the moment is my GP, I would say, which I suppose isn't fair, but I suppose COVID hasn't helped. I haven't actually spoken to a consultant for over 2 years. So I don't know where I'm supposed to start from really now. I am a bit lost at the moment, I think.
Thanks for sharing that, Liz. And it's a shame hearing that, and I think you're not alone. I suppose that's a good segue really to us discussing how frequently people should be monitored and what to expect from monitoring appointments, how to prepare for them, how to get the information we need, and also the role of a GP and the hematologist. I think that would be really helpful information. Somebody also passed a comment earlier that, you know, along similar lines, a question that they've had the disease, lived with CLL for 9 years, but only seen their consultant 4 times, with everything being remote. Now, is that a good thing? Is that a bad thing? Has anybody, I mean, John, have you, as a patient, would you like to share anything in this area?
Well, I think it's why we probably feel that things have gone to pot in the last 2 years, because we have every sympathy, particularly as my daughter's a GP. I hear from both sides. My side as a patient who generally, I've tried to phone my GP 5 times in the last 2 years, and it's taken me 1.5 hours to get through. So you pack it in really, and I write longhand letters now, and I get a cracking response from a snail mail. And I actually saw somebody at the local hospital after 2.5 years recently. A bit scary going into the hospital, but I really did feel good that he patted me on the head and said, yeah, you're doing fine. And that made a big difference. And I'm sorry to hear Liz is not finding that pat on the head, because it made a massive difference.
I think I'm suffering from a very recent, I suppose it was a mistake, but I was expecting to go in and have an appointment with someone in the hematology unit, and it was all some doctor rang me the day before, told me that my bloods were fine, which is wonderful, but there was no meeting, there was no apologies for the fact that there was at one stage I thought I was going to actually have a face-to-face meeting with someone, and I haven't got anywhere. And I've spoken to a doctor who I really couldn't understand, to be fair, on the phone. His foreign accent, I couldn't understand what he was saying. So we both ended up getting really frustrated with one another. And that was the end of the conversation. So it's left me feeling as if I'm getting nowhere, as if, I don't know. Or should I just...
It's sad to hear that, because I guess because I'm pushy, I want to look after myself, I have instigated my own blood tests over the last 2 years. So I get in touch, book an appointment, and I do my own monitoring by arranging my own blood tests. And that's kept me feeling more comfortable rather than being set adrift, as it were. Again, knowing how busy the medics are. I'm not being critical of the medics, but I guess fighting your own corner is a way forward, because they're just so busy.
Yes, there's a difference too between fighting your own corner and perhaps getting too cross and being rude or something, or them thinking that you don't care. Because I mean, I realised, I was a nurse myself, I realised that they're under a lot of stress. But on the other hand, I rather felt with this particular situation that I've been abandoned, yes, set adrift, definitely.
Thank you, Liz. And sorry to hear you feeling this way at the moment. I think we have our highs and our lows, and there's been all too many lows of late. And after 2 years with COVID, we're a bit more adrift. We begin to feel this. Our healthcare professionals, have you any insights you can share on how we can maximise as patients the opportunity to communicate with the different arms of our healthcare so that we're not cut adrift? And then maybe I'd also ask John after if you're involved in any peer-to-peer support within patient groups and the value of connection with the charities, of how you can gain some levers with charities, and also the value of connecting with other patients. But sorry, 2 questions in one. But healthcare team, you've been listening to a situation that's pretty real, and it's mirrored by many people in the comments. Any thoughts?
Can I make a couple of observations, Nick?
Yeah.
One of the problems is that there is no standard of care for what watch and wait actually means. We can't even agree on the terminology. You know, active monitoring, active surveillance is a much more positive term. For people who can never see their GP, can never see the hospital, it's a meaningless term. So there's no definition of what active monitoring actually means. And there's no standard of care. Some patients will be discharged to the GP, and the GP will assume that you will contact them if you feel unwell. Others will take it upon themselves to do regular blood tests and maybe contact you about how you are. Personally, I never discharge patients, even 20 years on. I still saw them at least once a year, just to keep an eye on them, back to that safety net. So one of the issues is the different terminology, what it means, and the fact in the UK, we haven't agreed what the standard of care for watch and wait active monitoring should be. If I had a newly diagnosed patient and said, I'm going to see you every 3 months for a year, and after that your GP will see you every month for 3 years, and you have a blood test every 6 months, everyone would at least understand what was meant to be happening. That's not the same as it would actually happen, but at the moment, there is no agreement of what actually should be being offered to this patient group. And consequently, people do feel left adrift from this for very obvious reasons. And I think one thing is trying to have that discussion with your hospital team of what exactly are they offering you if they say it's watch and wait. What does that mean for you as an individual? At least you can understand what the plan is, as opposed to, oh, we'll send you an appointment in the future, and that's the end of it. So I think there is terminology which isn't robust. There's definitions which are lacking, and there's no agreed standard of care of what actually we should be doing for the group. And then you would like to refine that to the individual, because some may not want bloods every 3 months. They don't want bloods at all. They'll tell you if they don't feel well, and they'll have a blood test then. It's very different.
Thank you, Chris. Charlotte, have you got anything you'd like to think about?
Yeah, definitely. I'd say from the other side, you know, I quite like a pushy patient. You know, I quite like somebody that's, you know, reminding me that they're there, and that they'd like a blood test, or like a review. I always encourage people to phone if they're worried about anything or want a blood test. So I don't see that as being a pushy patient. I think it's just really about being empowered, and I think you shouldn't worry from our point of view thinking, oh, you know, somebody wants an extra blood test they don't need. You know, if you think you need a blood test, then we would agree with you. You can have a blood test, and I think it's once you have that contact and the talk together, you can work out what people want, really. So I'd say don't be worried about contacting your team, and like Liz, I'd say go back to them. You know, have you got a CNS? Have you got somebody to contact in the hospital just to say, I wasn't very happy with my consultation. I didn't quite understand what's going on. Could somebody talk to me? You know, I think from my point of view, I'd love it if somebody phoned up rather than me know that they're worrying at home.
Bryony, have you any thoughts?
Yeah, I completely agree with Charlotte. I think we're quite lucky in Southampton, I think, because we keep people as Prof Fagan said, we don't discharge them back to the GP, so they're always under our care, whether that be 6-monthly follow-up, 9 months. The longest we have is a year, but they're always under our care, so they can always contact one of the team if they're worried for any reason. And like Charlotte said, if someone wants a blood test and they're worried, then we would arrange that straight away. And I think that's the way that it should be, but I understand that maybe that's not the way it can be everywhere. I can only say for Southampton. But we're looking at bringing in the patient-triggered follow-ups for patients that maybe don't want to come into these regular appointments, and they would then trigger it through my medical records and be sort of more empowered to arrange things themselves. But that's not something that we've managed to get going yet, but I know that's sort of something that we're planning to do. But it's really sad to hear that people are feeling left and abandoned. That's I'd hate to think that any of the patients I work with feel like that, and I'd always want them to contact me at any time, and we'll do whatever we can to help.
Thank you, Brian. And listening there, that there is no set standard of care is obviously part of the challenge, because it's finding somebody that you can talk to between appointments, because it's not just blood tests, is it? If part of the problem, I can recall as a patient myself, you go in to see the doc, and Chris, fortunately, used to be my doc. So Chris would ask me the question, how do you feel? And everybody gives the instant reaction, I feel fine, doc. Quite often during that time away from the doctor, you don't feel fine, or you've got issues that you want to bring to the fore. And it's a question of who do you bring them to? Do you take them to your GP? Are they the GP's responsibility, or are they the secondary care's responsibility? So there isn't a set answer then to the question is, who in my healthcare team can I talk to in between appointments? Is that what I'm getting from this, Chris, and from John and Charlotte is pushing until you can find somebody? Is continuity of care is another question that's come up, because I think I mentioned this to you earlier, Chris, when I was first diagnosed in Wales for continuity of care, my key contact was my consultant, because there was no CNS supported care available. Have anyone got any thoughts around, continuity of care?
At the moment, I feel that watch and wait means have a blood test and go home, actually, I'm afraid, because that's all the reaction I get. And perhaps I've not met the right people, I don't know. I was quite happy with it up until this last time, so perhaps I'm being a bit prejudiced, but I do feel a bit abandoned. And there's that thing, isn't there? There's no list of symptoms. I mean, what are the symptoms of CLL? How should I feel? How do I know?
That's a really interesting question, Liz. I didn't mean to cut you short there. It's actually the next question on the list that's come in, which is what symptoms might a patient expect to experience? When should they feel concern? When should they be able to talk to a healthcare professional? And there's talk of B symptoms and symptoms. There's some confusion about that area. That's something that people on Watch and Wait have to live with. Can you allude, Chris, to help in this area?
So there's really three bits of, is the disease changing its nature? One is actually symptoms from the patient. Are they losing weight? Are they getting night sweats? Are they getting fevers, especially not related to infections? And are they getting more fatigued? So that's one set of definitions. Another is actually related to the blood count. Is the white count going up rapidly? Are the platelets falling and hemoglobin falling? And then there's a clinical examination. So there's really three bits to tick each of the boxes. If you want to say the patient is definitely stable, you want all three bits of those to be correct. So usually when we first see patients, we tell them what to look out for. If you get this, give us a ring. If you get that, give us a ring. The point of the blood test and the clinical examination is to do those other two bits, because you can't do that at home, and you may not know if your hemoglobin is falling or your platelets are falling? How would you? Or your white count is going up. So the whole point I always see of why I saw the patient and didn't discharge them is care in therapy is more than just handing out prescriptions. It's a bit about education. It's a bit about encouraging the patient to take ownership. It's a bit about actually caring, what has happened. You will know, Nick, after a few years of dealing with you, you used to walk in with your 15-minute appointment, and I sat there and didn't speak to for 25 minutes while you told me everything. But that's part of the care. How is it impacting your life? Because again, a lot of patients are concerned about, I don't want to say silly things or look stupid, so I won't say anything. And again, if the emphasis is on the patient to make the contact, then for a lot of patients, they do feel left behind, which is, as I say, why I never discharged them. Because the fact they're not seeing me doesn't mean there's not issues out there. Yeah, in John being proactive, John's probably at one end of the spectrum. He's taken ownership. That's fine if you're able to do that, both you personally able, also if the system allows you, the GP, etc., is happy for that to happen. You need all these bits to work. But I'm very much that if you're not happy with your care, try and find another way of getting it with people you are happy with, or another system you're happy with.
I think that's sound advice. Whilst we're on the topic of symptoms, another question has come in, and I think that's quite relevant. I mean, it's interesting that you talked in your earlier talk, you talked about how blood count was less important than symptoms. And most of these conversations about monitoring from a distance about blood counts, because obviously as doctors and the care team, you haven't got sight of and hands-on care. So obviously the blood count becomes a lot more important. But so if we're talking about stable patients that will be very potentially asymptomatic and will maybe seen less frequently than others because they're stable over a long period of time, there are also symptomatic patients on CLL. So one of the questions that's coming is, have you got insights to help with managing symptoms, day-to-day symptoms, be it fatigue, be it increasing infections, any of those that you've listed as symptoms? Are there any insights to share to help people with coping with symptoms? John, there was a question I missed earlier, which was also about the peer support and the value of peer support.
Yeah, I think there's a couple of things. One is, as time has gone on for me, I've learned to read my body, and I think we can all read our body, and you become a bit more sensitive to it. And I find that, particularly if I have a bad day or a bad week, I just realize that I have to step back a bit, take a lie in, read more and cut out the physical, and obviously we've cut out alcohol virtually all the way, because that just gives you false readings, really, doesn't it? If to quote a phrase, if your blood's knackered, don't fill it with alcohol. And also we watched the diet, and I find that when perhaps you overindulge, your body tells you, whoa, back off from that. So if we overdo things, and my wife helps me with this, we just take some time out. And the other thing that I've found is, just shy of my 70th birthday, one of the big problems is what's CLL and what's just getting old. And you've got to manage that as well. And I think there'll be people out there who can probably have some empathy with that. I'm involved with the buddy scheme, and I've found that has been really good for me as the instigator and the lead buddy. It's helped me tremendously talking to people with leukemia around the country, sharing my anxieties with them and their anxieties with me, and their anxiety levels have definitely been up over the last 2 years. And we found communicating together I don't like the word therapy, but it has been therapeutic that we've shared our anxieties and helped each other. And I think it goes without saying, if you've got problems, share them. It doesn't matter with your best pal, your wife, your partner, your dad, your mum. If you're not feeling so good, talk about it, and that will help the waiting. You know, don't sit there and get moribund about it. Have a chat with somebody, and if you can't get through to your surgery, phone your best pal.
Thank you, John. I think that's really valuable. I think myself as a patient, it was a eureka moment the first time I ever met another patient, and they got it and they understood. And I think COVID has really impacted quite heavily on everybody because it hasn't given us the freedom to have those in-person connections with patients in patient groups. So it's probably a good time to, not as a plug, just to mention to those on the call that, you know, virtual support groups are available. There are networks of those available through Lymphoma Action here at Leukemia Care, Cll Supports, and the other organisations, and they are invaluable. I think if I was to impart any message as a patient, that's what helped me through the early part of CLL, and I found CLL watch and wait incredibly difficult, and Chris could be test, and also Charlotte, because Charlotte was in my care in my past as well, and I didn't handle it too well in the beginning. It was actually being able to connect with others and with the charities that often could help set your mind at rest. But that the thing you mentioned there is really interesting, becoming comfortable again in your own skin and being able to listen to your body. Is every time you have an infection or something's not right, I guess we're all overreacting potentially to some degree, because we have to be vigilant, which is what Charlotte said about worrying, but to a minimal degree, so you're not over worrying, is what's important and what's not, and what's CLL and what's not is really hard to pick the bones out of. I guess one of the questions that came in after this, and I don't know if it's related, was how proactive should patients be in their records, keeping records, they're monitoring themselves, monitoring their blood tests. Maybe this is something, the reason I'm raising the question is with COVID, many people are saying they haven't had the opportunity to have an in-person patient visit, or they're only seeing doctors or their care team. So how important is it for patients to monitor themselves and keep records? And on that same note, it's hinged off the back of that, are patients entitled to access to their test results, and who can help them understand them? So I would put that to Charlotte and Chris and Bryony, really.
Okay, I'll just go first. So I think I don't know the pedantics about whether they're entitled to results or not, but I think it's encouraged for people to be part of that monitoring. And I would say in the future, it will definitely be a much bigger part. I think, you know, there are patient apps already in circulation. Speaking from Cardiff, our renal team use them so patients can have a look at their results from home. And we very much wanted that in hematology. So I think that is coming. And I think it's part of looking after yourself with CLL is knowing what your bloods are doing and what you need to look out for. So I would say I'd encourage it.
Brian, I suppose ask yourself.
Yeah, I completely agree as well. We have a lot of our patients have the My Medical Records app, so they can see their blood results on there. They can also see clinic appointments. I don't think all the information is put on there because there's some things that need explaining by the consultant, but it's quite a good way of patients to just keep an eye on what their blood results are doing. I think there is sometimes a tendency, maybe people become a little bit obsessive about the blood results, and I think maybe to try and avoid, you know, sort of that worry and looking at something that's maybe slightly abnormal, or just get advice on it from the medical team rather than sort of you know, worrying about it. But I think it's a good idea for patients to do that, especially if they're having trouble accessing the medics.
Thank you, Bryony. John, do you keep your records? Do you monitor yourself closely?
No, I leave it to the professionals. I put all my faith in the professionals. They know what they're doing. I'm a geographer. I can colour maps in, and I wouldn't ask a doctor to colour a map in and certainly write me a letter. But I put every faith in them. They know what they're doing, and I tend to fight shy of that. I think there are two schools of thought. You can either get deeply involved in it, which for me would just raise my anxiety. I just like to go in, get the metaphoric pat on the head. If somebody in the medical profession says I'm all right, I believe them, and I leave it at that. And I think that's, for me, as long as they reassure me, they'll flag up something if I need help, and I'll lie back and enjoy it.
Thank you, John, for sharing that. And Liz, I'm really intrigued with your perspective and your approach. If you're willing to share.
Oh God. I've had a blank. I've had a geriatric moment.
Oh, don't worry about it. It's not. I didn't mean to put you on the spot.
Sorry.
No, it's not at all. I guess we all cope in the ways we can, and you know.
Well, I actually think about it. I actually have a thing called Patient Knows Best, which I can read them. I don't always understand them, but they actually give you the correct measurements and everything. So I do look at them. I think it's quite interesting. And you know before you see your doctor normally that, well, like this time, that my bloods were fine, really. So yes, I do look, but I'm not obsessed. I don't think.
No, it's interesting here. It leads me on to a question, which was from the doctors and the nurse support point of view. Early in CLL, you've just been diagnosed, and you don't know how stable your disease is, and neither does your care team. So obviously, there's going to be a bit more attention on you at that time. At what point, and I'm not saying you're cutting people adrift, but do you know how stable somebody's disease is and whether they need to be more concerned and keep a closer eye on it, or they don't? Are you able to answer that, Chris?
So my standard practice was to monitor the patient for 12 months. And the main reason for doing that is to see what the lymphocyte doubling time is. Have your lymphocytes doubled? Because some people present with a lymphocyte count of 10 and some present with a lymphocyte count of 100. Everyone is different. So to learn a bit more about the individual patient, it was usually 12-month follow-up, typically every 3 months, and then extend the appointment after that if I was convinced myself that they were probably going to be stable. We know that those people whose lymphocyte doubling time was less than 12 months in Cardiff, you were 7 times more likely to be one of the 50% of patients who progressed at 10 years. So we put a lot of emphasis on what was that. So if you turn that around the other way, if your lymphocytes haven't doubled in the first 12 months, you've only got a 13% chance of progressing in the next 10 years. It's not zero, which is why we don't discharge them or leave them to the GP, but you're in a different group because the lymphocyte doubling time is telling you something about the tempo of the disease of that individual patient. Because we don't know if you're stage A, whether you've been stage A for 10 years, if you've never had a blood test, or whether you've actually developed the disease in the last 6 months. And so that 12-month follow-up does give you a lot of information. And at the same time, what we were trying to do, probably more successful in some patients than others, Nick, is actually build that relationship with the patient, because you want that first 12 months to give you that foundation to build that relationship that may go on for 20 years. And that doesn't mean, as John showed, he doesn't have concerns or worries or anxiety. The fact he's 20 years on doesn't stop him worrying necessarily. But they always, for me, the most important thing was the first 12 months of care, because after that, we've learned a lot about you, you've learned a lot about us. Hopefully, we've discussed a lot. But I would just like to emphasize, to me, the gold standard of active monitoring, watch and wait is blood test, ask about symptoms, and examination. And that's one of my concerns. If we go into the new era of telemedicine, that examination is going to drop off. Now, usually the lymph nodes don't grow or the spleen don't grow without the white count going up somewhat, or the hemoglobin falling, or the platelets falling. But you do get exceptions with patients that, in fact, their lymph nodes will grow, but the lymphocyte count doesn't change much. And for those people with small lymphocytic lymphoma, SLL, they'll be used to that because the blood count is semi-irrelevant until you get really advanced stage disease, and then you're looking for the hemoglobin dropping and the platelets. So the gold standard should be all three. And unfortunately, if we move into telemedicine, and we are trying to catch up in the health service, there's going to be pressures to drop some of those things. And although the risk is small not being examined, it's not zero. Your disease can progress and your blood count not change very much. Usually the three go hand in hand, but not always.
Thank you, Chris. So the challenge is going to be keeping people connected in between their longer term appointments post the 1 year mark, and getting people, us as patients, to a stage when we can take ownership of our disease, understand it in our own body and how it reacts in us. And that takes time. It's very hard to take on board early on in your journey when you're first diagnosed. And you can be sent in lots of directions, and it leads to the next question that I probably got is, can patients slow down CLL progression or reduce the chance of ever needing treatment? Are there activities other than good health, which Charlotte pointed out earlier on in her introduction? Would the clinical team like to answer that question? Because I think many people that have recently been diagnosed might be looking at strategies that will try to prevent progression. Have you any thoughts in this area? Maybe Chris, sorry to throw it back at you as the professor.
There are no proven things a patient can do to actually stop progression. It's in the biology of the disease. There's reports on vitamin D levels. You're more likely to progress if your vitamin D levels are low. But when you actually give that group of patients vitamin D supplements, it doesn't stop it progressing. So it's probably just a marker of something else. Likewise, green tea, dietary things, there's nothing been shown to make any difference in a meaningful study. But that's not the same as saying you can't be proactive at keeping yourself well, because you may be one of those 50% who ultimately may need treatment, and looking after yourself in those early years will pay dividends later on. I suspect vitamin D levels at the moment will be absolutely rock bottom in the CLL fraternity because no one's leaving the house. And of course, if you live in Wales, you haven't seen the sun much either. So the fact that you turn up and your vitamin D level is low and you've progressed is not the same as you progressed because your vitamin D level is low. But that the terminology now is prehabilitation, making yourself, making yourself as fit as possible should that day arrive when you may need actual therapy for your CLL disease.
Thank you, Chris. I've noticed somebody just posted something about a symptom that's obviously quite personal, but it was a question raising, is increasing bruising and susceptibility to bruises a symptomatic sign? Is it a sign of progression? I could imagine that could be many things, but it is something that somebody should follow up with their clinician.
Yeah, increase in bruising can be due to, dare I say, aging. Our skin gets thinner as we age. Unfortunately, everything wanes a bit. So easy bruising, especially forearms, is often just part of the aging process. But certainly you should think about, are your platelets dropping? And that may not necessarily mean CLL progression. 1 in 50 patients with CLL will develop a thing called immune thrombocytopenia purpura, where you've actually produced antibodies which stick to your own platelets and drop them. And that's not the same as CLL progression, there's specific therapy for that. So certainly when I'm asking about is the patient increase in bruising is something that I think should certainly warrant a blood test. Because if the blood test hasn't changed, platelets are above 70, 80, then it's probably nothing to worry about. So it'll reassure you that actually there is nothing changing. But the only way to find out is to do a blood test.
Thank you for that, Chris. I just thought I'd ask that question as it was thrown out there. We can't normally deal with personal, but it's unidentifiable. So from that point of view, it follows on from the monitoring is keep a record of signs and symptoms that you might be experiencing and make sure that you talk to your care team when you're in contact with them. I'm going to jump to another topic that people have covered is how do they actually, how do patients with a counterintuitive diagnosis, you're told you've got a cancer, you're told it's incurable, you're told you may need treatment, you may not treatment. And if you do need treatment, it might not be for a long time. And if you do have treatment, it might have to be treated again. But actually nothing's happening. And it's a difficult, so I wanted to, if we could, approach the topic of talking to others about your diagnosis. You know, who should you talk to and who should you tell? Is there a rule? Is it individual? Who should you tell that you're on active monitoring and how do you do this? Is there a way, have people found a way to explain this bizarre diagnosis and living with it to their family and friends? Has anybody that they could impart there for people that have been, you know, given active monitoring as their treatment plan? Because it doesn't fit with how everybody else around us sees a cancer diagnosis, and there are some complications that can come with that. I'm just wondering, maybe John, have you had to tackle this?
Yes, it started from the very beginning. I never sound ill, and because I've generally had a tan from the North Walian sunshine, I always look fit and well and sound it. So the best advice I was given was from a nurse when I was first diagnosed, and she said, never keep cancer secret because you can't hide it. People will make it up if you don't tell them. So from the very beginning, I've been totally open, totally honest, and sometimes I will even tell strangers because people need to understand that even though you look a normal human being, for example, you got to isolate at the moment and people are saying to me, well, you look fit and well, why aren't you coming to the pub with us, or why aren't you coming to the sailing club anymore? And you just have to explain, you know, I've got leukemia and I've got to keep myself out of the way for the time being, but I'll come back with vengeance when it's all gone away.
Thank you, John. Liz, have you got anything you'd like to share in this area? Have you had challenges communicating with others?
I agree, actually. The best thing is to tell people, although it can kill conversations dead. I do know that. But eventually, I think the thing that people don't understand is you know, you've got cancer, but nobody's going to treat you for a while. And you get all sorts of remarks like, well, shouldn't you get a second opinion? You know, is that right? But I think the best way, and I think it's probably what I do, I mean, all my friends at golf and art all know. And that's helped during lockdowns because they understand why I'm not in the art class or up in the golf club having coffee or something, you know. It's I think that's the best way to go.
Thank you, Liz. That's, I guess I've got there's another question that's coming that's similar to this is, and Charlotte, you raised this very early on in your slides about how important it is to talk to other people. They're your support. But what do friends and family need to know to help somebody that's on watch and wait? That's the question. I'm just wondering what people's perspectives are there from the clinical point of view. What do friends and family need to know of somebody that's been diagnosed with CLL and is then on watch and wait? Is there something you could share there, Charlotte? Any insights?
Yes, I mean, I'd say, first of all, I think if you are telling anyone, really it's good to sort of tell them where to look up information, because there is a lot of frightening information out there. And I think when it's all in a label, really. If you say you've got leukemia, it is a frightening word, and you know, it is that chronic bit that puts slightly different perspective on it, but you need to find out credible information. So if you are telling people, maybe also tell them where they can find out a bit more information. And really, I suppose it's the people that are most important to you that you want to include in those sort of reviews. You know, they need to know where you are on the sort of leukemic continuum. You know, are you going to be having treatment soon? Are you not? Do they need to start worrying about you? Do they need to keep an eye on you, or not? So I suppose it's about telling specific people specific things. So your friends around you that you just want them to understand a little bit, get them to read up about CLL. Those that are closer to you, really include them in what's happening with you.
Thanks, Charlotte. That's really helpful. Brian, have you got anything you can share on what you impart to family and friends and patients in an understandable way, so they can take on board this counterintuitive diagnosis and lifestyle measures?
I think, as Charlotte said, it is really important that they know, you know, what kind of leukemia it is, because it is a frightening word. And I just saw someone in the chat just brought up about their children, and I think that's really yeah, a very personal thing. I don't even know if I would tell my children, if I really wouldn't know how to advise on that. And I thought that was an interesting point that they've made, and I'd like to know what patients feel about that. But in terms of sort of friends and family, especially around sort of the COVID time, I think it's really important that people know that you are at high risk, and I'm sure that they'll be supportive, you know, to help you and support you while you are having to sort of stay away from people. So, but yeah, I would like to know what people feel about sort of telling their children. So that's a very interesting point.
Because I could share a little bit on that myself, actually. That was the reason that, sorry, John, that you 20 years you've had to do the same, I would guess.
Yeah, I think 2 points from what Charlotte said. It does help to give people signposts, and Leukemia Care website fills in a lot of details for family. The one thing I mentioned to folk is, whatever you do, don't get through to Mr. Nutcase from Cincinnati, because he'll scare you to death, and he's a nutcase. So get professional websites, not gobbledygook. I had a really bad experience with the children. They were just about to do GCSE, and I got the phone call on the Monday night to say, John, there's no easy way to tell you this. You've got cancer. And of course, my stomach dropped to the floor. I didn't hear any more of the telephone conversation, put the phone down, walked in the lounge at 6:30 in the evening, sat down, looked at the floor, and Andrew, Fiona, and said, well, what's the matter? I've got cancer. Well, that went down like a lead balloon. So 2 pieces of advice: don't get involved with websites in Cincinnati, and be very careful how you tell your children.
That's really sound advice, John. I suppose I could share what I was going to share earlier. The reason I actually became involved in advocacy was my first foray into contacting a charity was when my daughters were at primary school and I was diagnosed, and I didn't know how to talk to them about it. And I was given varied advice, and the advice I was given was go at the pace of the children. And I made some mistakes. And I'd like to share to everybody, that was 13 years ago. You know, I was worried at the time of diagnosis that would I get my children through secondary school? well, now they've graduated for university with firsts, and I'm a proud dad, and I'm feeling as well as I was, and I've been treated twice, and I'm in the treatment now. So it's amazing how things change with time. But I made an error. One of my daughters, I thought I had given enough information, and only twigged that I'd been living with a leukemia until they were 18 or 19, when I was going through an issue in life. And we struggled in the relationship because of that for a couple of years, because I hadn't been open and honest. I guess it's down to everybody's individual, but the advice that I was given was go at the pace of the children, in terms of, you know, from that point of view. I guess what leads us on, as I'm mindful for time, and what we're looking at is types of information and support that are available from charities. So Charlotte has really shared a lot of information, and the slides, you know, what I've learned as a CLL patient, and I don't know about yourself, John, about others, that I always used information support through my journey as a snorts, like the Americans would call a smorgasbord, and pick a piece from here and a piece from there. And peer support is probably one of the greatest areas of support, where you can come together and share experience. So you've got experienced patients with newer patients. But I think from the questions that we've got in, and the time shortage we've got, I've got a few slides that I can share to share services and support from Leukaemia Care. I've really just wondered if everybody's got any parting statements or things they'd like to raise at the moment. If I started with yourself, Chris, bearing in mind we've got about 5 minutes.
Nothing really for me, but I would just reiterate, if you're not happy with your care, do something about it. You shouldn't put up with second rate.
Charlotte?
I would say use your CNS, find out who it is and actually use them, because they are a great link, and they'll stop all that worry about not knowing who to phone and thinking nobody everyone's too busy to care.
Bryony?
And I would say on a similar vein, to use the charities. I think the buddy schemes are fantastic, and they've helped a lot of patients I've worked with. So yeah, really make the most of what the charities have to offer.
John?
Two final remarks. One is it's an opportunity for patients to thank both the medical establishment and you folk in particular for all the hard work you do. Mm. You're on an uphill struggle. We know it's not easy for you. So I'd like to take the opportunity of thanking you and the charities. Without the charities, I know I can pick the phone up, speak to Leukaemia Care, and I get help. And I would always recommend, if you're feeling a bit browned off, or you've got an issue and you're not quite sure and you can't get the medics, give Leukaemia Care a ring, because they've always been great for me. So thank you.
Thank you, John. And Liz, would you have anything you'd like to add at the moment?
Well, I've learnt a lot from what you're saying, because I perhaps hit a rock, but I'm probably not looking in the right places. I've not really used the charities, to be quite honest, not in perhaps the way I could. So perhaps that's something for me to be doing. I mean, by the sounds of it, I mean, you've made me feel better about how I was feeling when this started. So, thank you.
Thank you, Liz, and you're not alone. And you know, from that point, I think I'd reiterate what everyone else is saying: is reach out to what changed my life was reaching out to the charities to find others living with the condition, living with these challenges. People have had to do it before us, people doing it for a long time. That is really helpful. And reiterating, really, I like the words, be a pushy patient. Don't be frightened to push if you have issues. Be a pushy patient. I've got some slides to share with you, and I'll just run through those. That'll help with signposting you to some of the support and facilities that are available to you, and we'll forward the slides afterwards. And so if I could just run through the slides, and then I'll say goodbyes and thank yous towards the end. That's if I'm managing to do this correctly. Is everybody able to see my slides?
Yes.
I have a feeling that I apologize to everybody, a little bit of a technical glitch going on here. Okay. So these slides will cover some of the service events. So at Leukaemia Care, obviously you're on a webinar today. We're running a series of webinars through the years. So this is a really useful way to keep up with information. Also at the same time with our support groups, who this year we're looking to align support groups so that they also have the ability for patients to be able to follow on from webinars where you might have picked up more information to then be able to do what we were talking about earlier, which is having some peer-to-peer engagement and come together a group in support groups. Newsletters and magazines. We've just published our newsletter. I'll have that on the next slide to show you. Is a great way to keep in touch. So if you get a chance, sign up to permissions, let us know, through the website what information and materials you want. And that is a great way to keep in touch with everything. And in a fast moving landscape at the moment, like with COVID, it's a good idea to be connected with one of the major charities to keep on top of everything. We offer a range of podcasts, which are frequently updated, run by Charlotte. Social media, we have quite a few active channels, and the website. Patient information books are invaluable. I noticed when I was diagnosed with CLL that I was given loads of bump in the beginning, and I didn't really visit much of it until a few months into my journey. But very helpful booklets on watch and wait and understanding watch and wait and how to cope with watch and wait. These are available free, plus different stages in the CLL journey. These are available through the website. We'll share the slides afterwards so that you can actually access the links. But if you visit the website, you can actually get the information. Our latest quarterly magazine, Leukaemia Matters, was published over the last few days. So that's also available free online. You can have that delivered to your door in a hard copy. Really worth a read. It's really broad and informative and shares a lot of patient information. And it's quite fulfilling sometimes to read the magazine to see how others are coping and new medications, new treatment, what the charity's doing to help you, information about other things going on with COVID and everything else. And it's well worth subscribing to. Support site. So we were talking about different areas that can help people. The helpline is always there. Never be frightened to use the helpline. That's staffed at Leukaemia Care by clinical nurse specialists and our support care team. And that's also, we run a WhatsApp service, so you've got real-time communication as well. Our virtual support groups, like some of the other charities that Charlotte mentioned, we've got a national network of local support groups, plus we're also now running national disease-specific or topic-specific groups that will align with webinars. We have a welfare advisor, so obviously very poignant in today's climate, especially once receiving a diagnosis of leukemia or being housebound. The service, we offer advocacy support, both one-on-one support or general support. So if you're having problems communicating with your healthcare team, if you're feeling that you're cut adrift on watch and wait, great way to connect with the charities, to have a word with advocacy to see if they can help with connecting you with who you need to talk to, within your care team. Somebody mentioned online forums online. There's the Health Unlocked forum for CLL, which is run by CLL Support, which is very busy, but we also provide Facebook, have a quite busy Facebook group, and the buddy scheme is incredibly successful in CLL for those on watch and wait and all stages, which John is testament to sharing. We also offer a counselling fund. There's a lot of emotional and psychological challenge with living with the diagnosis, and especially coping at the moment with COVID and being immune challenged, and all of that comes with it. So don't be frightened to reach out. There's a counselling fund here that's available to people before treatment, during treatment, and after treatment. We don't differentiate between what type of patient you are and where you are in your journey. Just to flag to everybody, well worth a visit. If you're not confident enough to go to an in-person meeting, I think this is a virtual meeting. I'd need to confirm that with colleagues, but I'm assuming it is the 3rd of May is our CLL Watch and Wait national meeting. So all of you active monitorers, active surveyors, watch and waiters, great way to come together on a call so that you as a group can share experiences that we all live with on a day-to-day. And that I personally always find more valuable is talking with other patients. I think we talked about the buddy scheme. We're always looking for experienced patients to help with the buddy scheme. And if you want to connect with somebody that can share their valued experience on a one-to-one basis, invaluable. Again, something that John champions. I talked about advocacy caseworker, and I also talked about a welfare officer that's available. Very poignant in today's times. We're always interested in those that are adventurous and those that are prepared to help fundraise so that we can continue to support everybody with the services that we do. So if you fancy it, go down the largest zip wire in Europe. I think that's in Wales. This one it is, yeah, Penrhyn Quarry, 14th of May. A little fundraiser. If you can raise a couple of £100, entry fee 25 quid. Something I'm actually looking to see if I can get on. So there's plenty of fundraising opportunities, small ways that you can help others. Please have a look on the website. We're quite active on social media. Keep an eye open, join in the conversations. Again, I think I've touched on, I think there was a slide missing. I also wanted to point out that we have a Watch, Wait, Worry campaign that was launched in April, which was, you would have seen on one of the earlier slides. Please do drop into the website as Watch and Waiters and have a look at the campaign. Help sign a petition where we're raising awareness of the challenges of those on active monitoring to actually improve service and support. And also, if you're social media active, share a watchie, take a photograph of yourself with your watch, share it and join the campaign online. I think we're going around in full circles here. Helpline, I've touched on earlier, and you can email. These are our contact details for the helpline or to email. Sorry if I bumbled through that. My slide deck wasn't working as well. May I just take this opportunity to thank everybody for giving us the time, joining us today, and especially for our terrific panel. And, I have to thank personally Charlotte and Chris, first name terms, become great friends over 13 years, 14 years when I rocked up in their office one day, almost hysterical at the point of diagnosis with the cancer. And 13 years on, I'm able to join a webinar and share their great experience with everybody else. And thank you, John, for very much for giving your time to share your considerable experience. Liz, for joining us, and I know it's not been easy today and we've had technological problems, so thanks for them. And Brian, it's fabulous to meet you. Thank you so much. And everyone keep up the good work and live well with CLL. And let's hope the spring and summer brings something a little bit more positive than the last winter has. I think we need to be able to spread our wings a little bit. And trust yourself, trust your body. Time is not your enemy. Time is your friend. Watch and Wait gives you time. There was a friend I met of Professor Chris Fagan's, another Professor Chris actually, and he did this great study of all of these prognostic markers that I was trying to learn to understand how my CLL would behave and everything else. And even the scientists, and he put everyone's nose out of joint because he said, time is the greatest prognosticator of all. And that's something that I learned. And let's help each other get to the stage when we become comfortable again in our own skin and able to cope with living on Watch and Wait. And just thank everybody. Thank you for a good session, a terrific chat, and goodbye, and have a good evening.
Bye everyone. Keep well.
Bye everyone. And please do write in if you have any questions. We'll pick up any questions that we can from the chat and see if we can respond to you in follow-up. Thank you very much.